Okay, I have with me today Dr. Gordon Caldwell. I'm going to tell you a little bit about him first. Dr. Caldwell was a medical student at Oxford University and King's College Hospital, London. He completed postgraduate training in medicine, diabetes, and endocrinology, and was a consultant in Worthing from 1993 to 2018 and in Oban from 2018 to 2022. And he contacted me recently regarding the Lucy Letby case and regarding the book that I've written. So we're really privileged to have him today. So without further ado, thank you very much for joining us.
Thank you, Chris. Yeah, just reiterate what you said there, that I qualified a long time ago and retired 4 years ago. And in addition to those areas of expertise you mentioned, I had particular interest in quality and safety at the bedside, um, teaching and training of junior doctors and of nurses, and of the use of IT at the bedside. I think those we recognise as my areas of expertise, and also did quite a lot of work on process control and quality control on ward rounds. Thank you.
Yeah, I mean, that's going to be an interesting thing that we'll hopefully discuss today. Um, you have a particularly, I think, fairly unique insight into ward rounds. So I think that's going to be an interesting topic to discuss. So what I usually begin with asking people about is how they became concerned about the Lucy Letby case. But I know that you told me a story about this involving your wife, so perhaps you'd like to recount that story.
Yes, my wife is a retired nurse, a senior nurse, and she during her career she had worked in intensive care units, particularly in the Birmingham area. And although they're adult intensive care units, they sometimes had young children, not neonates, but very small, very ill children there. And when she started talking about the case, she said that she'd seen a lot of the incidents that were being attributed to deliberate harm arising as part of ordinary care. So an endotracheal, a breathing tube coming out of place in one of these tiny children is fairly much an everyday occurrence. The children are so small, they're very delicate, little movements can dislodge the tubes. And for example, finding blood around the mouth, again, would not be unusual because it's a little traumatic having the endotracheal tube put in, and often they have clotting abnormalities and such like. So she said that most of the things that had been alleged as deliberate malicious harm, she had seen as parts of ordinary everyday process in intensive care unit with children. The one area that she admitted she didn't know anything about was the insulin cases, but otherwise she was worried that a professional nurse was being held accountable for a series of events which could just have been part of ordinary care. So, and then she started asking me more questions, and I had assumed that if this case had reached such prominence, that all the all the cases where the children had died or been harmed had been thoroughly reinvestigated by teams of experts in those areas of care, pediatricians, anaesthetists, biochemists, pathologists. Particularly, the pathology would have been reviewed, and there had been forensic reassessment of the cases to prove that the children had been murdered. And then it became increasingly apparent that that wasn't the case. And in fact, I think there's isn't particularly strong evidence, or there's no evidence that there's actually been murder in the first place. So somebody can't be guilty if they haven't proven there's been murders. Um, and then with my experience of adult intensive care, because of course a number of my patients ended up on intensive care, and I worked in intensive care early on in my career. Um, that some of the ways they're postulating these children have been murdered seem bizarre. In particular, the idea that you could kill a baby by putting air or fluid into the stomach. It just is an implausible mechanism to kill a child. I hadn't ever heard it proposed for a child or an adult ever before this trial. And the reason you put nasogastric tubes down a lot of the time is to let liquid and air out. So they're proposing that you kill the child somehow by putting, and that just seemed implausible. And then a quite separate thing, which is often there's made an adequate distinction between the two. Injecting air into the stomach is totally different from injecting air into a vein or into a central part of the circulation. Injecting air into the circulation is an extremely serious thing to do. It's called air embolism. And in intensive care units, when central lines are taken out, you take precautions to make sure air doesn't get sucked into the central venous system. And if it does, and there's enough there to kill a patient, then the right side of the heart, the right atrium, the right ventricle, the pulmonary artery will be full of frothy
Mm.
frothy blood because the air's there and the blood can't get through the heart anymore. So circulation stops and the person dies. Now, I have not read any indication in the pathologist's reports there's ever been any air found inside the circulation. And so those children did not die of air embolism because it would be patently obvious when the heart was opened that that was the case. Um, so it just seemed to me that, again, that taking up on what my wife had said, there seemed to be little evidence that murders had occurred. And if they had occurred, there was little corroborative evidence that any particular person was guilty. Um, so I've been brought up early on in my life to respect the justice system in Britain. The founding principle of our justice system is that innocent people aren't convicted. Now, that may be at the expense of a few guilty people getting off,
Mm.
but that's how we prefer to run the system in our country. And somebody should be, if they're guilty, it should be beyond reasonable doubt. And it doesn't seem to be the case in this case.
Yes, I think.
The logic, I think, as well around this funny thing about the skin rash. Um, they said, oh, there was this funny skin rash, therefore it was air embolism. Um, well, that reminded me of the first lesson in logic my father gave me, which is all policemen wear blue hats. This person's wearing a blue hat. Are they a policeman? Well, not necessarily. But they
Mm.
don't seem to have gone past that very elementary piece of logic.
Mm.
Here's an extremely rare skin rash, which occurs sometimes in a very rare condition.
Mm.
But there's plenty of other causes for rashes, and we haven't got pictures of that rash. We don't, even if it was what's called pathognomonic, um, we still don't have the evidence. So to me, the whole story on the air embolism side seemed wrong.
Yes. I should emphasize as well that this was lent on heavily in the
Mm,
court case. It's not like they mentioned discoloration or mottling once.
no.
It was repeatedly all the way
Mm,
cited as the smoking gun as to why it
mm,
was air embolism, why it was air. And
yeah.
of course, I think that's why so many doctors have come out to say, I mean, come on, this is
Mm,
ridiculous. But yeah, that's very, very interesting to listen to. We're obviously going to discuss Lucy's case in more detail, but I want to also talk about a few other topics that you've mentioned to me. Now, the first one, I happened to encounter a podcast that you did in which you're talking about the high levels of bureaucracy
mm.
in the NHS. This is something I think most people will have heard about. So could you explain a little about that? And also, I was wondering, do you think that can have an impact on a hospital that I think is quite evidently failing, certainly the neonatal unit,
Mm.
such as the Council of Chester?
I think the excessive bureaucracy and difficulty of finding relevant information affects all hospitals in the NHS. And so if you have a hospital which is failing, it's going to have a more profound effect. Um, it's sometimes difficult to bring it home to people what I mean by this excessive bureaucracy. But for example, my last week I was working after 43 years in the NHS. I was working in a clinic for people with mini strokes, transient ischemic attacks. I was given half an hour to see each patient, but I had to fill in four separate radiology request forms for each patient by hand to get the relevant tests done: CT scan, echocardiogram, carotid Dopplers, chest x-ray. So 15 to 20 minutes of that consultation was taken up with just filling in forms.
Hmm.
So that's obviously a nonsense and something that should have been sorted out years ago by proper use of IT.
Hmm.
But also at the bedside, the sort of situation that common is that you want to know the working diagnosis in the patient, maybe their admission weight, the medications they're taking, the allergies, their current blood glucose level, the blood pressure, and the respiratory rate. And just finding that sort of information and whether they've gone to the toilet that day, just finding that sort of information can be a major undertaking because there's so much bureaucracy. You can't find the stuff that you want inside it. So that occupies our brain with finding the stuff and getting irritated rather than releasing our brain to think, react, and consider the case and what's going on. So it distracts our limited brain RAM from doing what it needs to do, which is my patient getting better? Are they getting worse? What's going on? What do I need to do to remedy the situation? And that's just common right throughout the NHS.
Hmm. So do you think that can impact on, the Counter Chester or
Well,
anything hospital?
I think it can affect every episode of care where in
Hmm.
hospital, whether inpatient or outpatient, because in all those situations, the doctors are desperate to find reliable information, and it can be difficult to find and bogged down with unnecessary procedures. I mean, you probably know there's a whole lot of stuff about whether we should have physicians' assistants or not and what they should be doing. My work would have been dramatically improved by having somebody who could read and write in the clinic with me and could write those 4 request forms,
Hmm.
let alone putting it across to a computer, which could have done it in half a second.
Yeah.
Um, so whenever you're at the bedside, just as a pilot needs an array of information to fly the plane safely at any moment, the doctors and the nurses need that array of information in a visible, understandable format, quickly accessed, and it's simply not there. So
Hmm.
every episode of care can be affected by that.
Yes. Well, it's interesting. And the other issue that we're probably going to discuss in a bit more detail was you mentioned to me the cases of David Sellu, who I'd never heard of at all,
Hmm.
and Hadiza Bawa-Garba, which I had heard a little bit about. And in these cases, serious adverse outcomes occurred against the background of wider systemic problems. So could
Hmm.
you firstly just explain a little bit about those cases?
I think I'll reiterate again that principle of justice in our country is that innocent people are not found guilty. So we have very few, in medical terms, false positives in the system. Now, Dr. Bawa-Garba was a registrar in pediatrics, and she was found guilty of gross negligence manslaughter of a child. The context was she'd come back to work after a period of maternity leave. She hadn't had an induction into the new department, which she'd never worked in before. That day, there were meant to be 2 registrars on duty covering the heavy workload of children in A&E and on the wards, and one of them was absent, so she was doing 2 people's work. Um, the consultant on call, who's meant to be in the hospital, readily available to help with any difficulties, was 40 miles away at a conference. And she was working against almost impossible odds.
Hmm.
And in the midst of that, a child was admitted with pneumonia. Apparently, seemed initially to be getting better, later deteriorated and died. Um, and when the hospital investigated this, they found many failings in the processes. The IT systems weren't working, couldn't see results. Many changes that needed to be made to improve this to protect against it happening again. And
Hmm.
despite those many failings, she was found guilty of gross negligence manslaughter.
Hmm.
And partly this was down to the expert witness, who, as I understand it, was a neonatal intensive care doctor who said anybody should have been able to identify this child as seriously ill and needing attention. And I'd say that that expert was the wrong expert. The context she was working in was a busy accident and emergency department and a general pediatrician. So it needed an A&E consultant to be the expert witness. When you're working in the intensive care unit, all the difficult bit of sifting out the 999 children who don't need to be there has been done. And you're left looking after the one that's been found to be ill. Um, with David Sellu, his oh, and I think the other thing to mention about Dr. Bawa-Garba was that they used her personal reflections on the case as
Hmm.
evidence against her. Now, when doctors, all of us were encouraged to write reflective diaries about our cases, and particularly then to learn about how things could be improved. Now, there were bits taken from her private, personal, confidential diary, which never meant to be read by anybody else apart from the educational supervisor, and used as evidence against her. Now, that cut off huge potential learning for doctors and for the system, because then the junior doctors would no longer be willing to discuss cases that went badly because they might be used as evidence against them. And I know of junior doctors who then wrote in their personal diaries, I reflected on a case today. So there's a massive amount of consequence of loss of learning from that.
Hmm.
With David Sellu, again, it's a very complicated situation, and a patient died. It wasn't his patient. It was a patient under another consultant who had done an operative procedure on the patient. There were a series of very unfortunate events that resulted in the patient's death, and he might well have died in any case. Again, there was an internal inquiry in the hospital he was working in, and there was no blame put against him. It was, again, a series of events were identified, problems identified, and somehow at the end of that, again, the coroner decided that there'd been gross negligence, um, and he was found guilty in the Old Bailey and sent to high security prison. Um, but eventually, his case was quashed. Bawa-Garba's case was never quashed. His was quashed because the expert witness had led the jury. And the expert witness said that any surgeon who saw a patient in need of intravenous antibiotics would wait to see the antibiotics written up on the drug chart, wait to see the antibiotics drawn up, and wait to see them given before he went on. Now, how an expert can claim that when I've never seen a consultant surgeon do that in my life was so the expert in that case led the jury. Fortunately, the conviction was quashed because there was no question in my mind that David Sellu had behaved in any way other than utterly professionally throughout the whole episode. And I think it's to do with society's respect for expertise and complexity. And in my thinking over my career, we've got less and less respect for expertise and complexity. And we look for really simplistic, quick answers to things. To the extent now we seem to judge people in an internet discussion through social media rather than proper, thorough due process and with respect for the complexity of professional work.
Yeah. So that's all. Obviously, that has enormous relevance for Lucy's case. I think it's very interesting to highlight those cases. So we're going to talk firstly with regard to the Lucy Letby case about ward rounds.
Mm-hmm.
In common with many other people, you expressed to me a great deal of surprise about the apparent frequency or infrequency of ward rounds on the unit. And this is particularly relevant because you have co-authored academic papers on ward rounds. So could you tell us more about that firstly?
Yes, well, I'd say that what struck me was the infrequency of the ward rounds, whereas you said frequency. And I think they said they were doing ward rounds twice a week.
Hmm.
Um, Now, historically, ward rounds, I think, have just tended to happen every day because everybody's at work every day, and so there'll be a ward round every day. But I think as medicine changed in the 90s and 2000s with increasingly junior doctors working in the teams and the teams being fragmented, it was clear that needed consultant-led ward rounds on a much greater frequency. The wards where I worked were general medical wards, where downstream from the admitting wards and coronary care and such like, and a daily consultant-led ward round became the norm, certainly during the 2010s and extending into weekends. But that reflects the pace at which patients might change. Occasionally, there'll be somebody who is more ill you needed to see twice a day, but generally, reviewing progress after a day made sense. You could pick up whether the person was the same, getting worse, getting better, maybe even getting better quicker than you expect. But in an intensive care unit, an adult intensive care unit, the norm was 2 full ward rounds a day, 7 days a week, because the patients are critically ill. That makes sense. And there can be changes very rapidly, results come in and such like. So I would expect in neonatal intensive care unit, the highest level of intensive care there is probably, trying to save these tiny little babies, that absolutely minimum would be once daily. And as we said, expect it would have been twice a day. So twice a week is quite extraordinary. And in addition to that, you'd expect 12 hours a day during the day that the consultant would be on hand. Babies suddenly get delivered unexpectedly. The consultant should be on hand to come and see the child probably within an hour or 2 hours of the child arriving in the neonatal intensive care unit. So that just seemed way away from what should be the case. At night time, again, I would have expected there to be a very senior trainee in pediatrics responsible for the unit. Maybe a doctor who had qualified 8 or 9 years previously, was committed to a career in pediatrics and possibly committed to a career in neonatology. So they've got people with the expertise who can do the procedures that are necessary on these tiny babies. So, I just couldn't believe that. And when Dr. Lee and his team reported back, I think they said they wouldn't have licensed the unit in Canada.
Mm.
Well, I could believe that because they would expect twice a day ward rounds. If they weren't happening, lose the contract.
Yeah, absolutely. In addition to the frequency or infrequency, you also expressed to me some views about relatively junior doctors conducting neonatal ward rounds without the consultant being present and
Mm.
supervising them. Why is that? Why is that significant? And what kind of problems could that lead to?
Well, it comes back to my point about expertise. I mean, I think most of us believe that as doctors, you need to have a vast amount of knowledge and understanding of how the human body works and doesn't work and what's going on in illness. But as you work more and more years, you get more experience and can recall events and diagnoses and conditions and spot signs of deterioration, for example. And just the business about being able to think as well. It's a very difficult thing to be holding forth, running a ward round, talking with the parents, talking with the nurses and everybody, whilst you're trying to think, is this child getting on and what could possibly be going on? So it's a big cognitive load. So in adult medicine, I said I was interested in teaching and training. For the last 20 years, probably in my career, I was willing to let a registrar run the ward round, but I was standing there observing. And I found that in a sense, it was quite liberating because it gave me much more room to think as well about what was going on and whether the person might be deteriorating or whether the registrar had missed something completely. And that helped them to train with confidence. They knew that they were doing the ward round. They had somebody commenting on whether they were doing well or doing poorly, what they could do better. Um, and that's, again, I haven't read the grades of these junior doctors who are running the ward rounds, but it got the feel to me that they might be GP trainees and some fairly junior trainees in pediatrics. And they simply wouldn't have that expertise. Yes, they could spot big things if the child has a cardiac arrest or pneumothorax or sudden hemorrhage, but to have the expert skills of a professional, they wouldn't have that. And that's why all the colleges have emphasized the need for consultant-led ward rounds.
Yeah. I think it is fairly clear from everything that I've seen and everyone that I've spoken to that there was essentially poor monitoring on this unit, and that has been at the very least a contributing factor into why they missed
Mm.
signs that I think sometimes were subtle and sometimes were not that subtle, and they probably should have seen them. Um, so let's discuss. We've got many medical issues to go into here. Um, One of the things that you mentioned that we had a bit of a chat about was this idea that the infants were stable
Mm.
before suddenly deteriorating. This is how it was presented in court. Um, and you essentially said to me something that lots of I mean, I think I understood this before I began researching this case really, but you mentioned that stability doesn't really mean a great deal. So explain to us what the term stable really means when you're talking about a premature or seriously unwell infant.
Well, I think stable is pretty much a lay term. It's not a professional term, I
Mm,
don't think. And you'll read there was an accident yesterday, 6 people admitted to hospital, two are in ITU and are stable.
mm,
Well, that means their condition isn't deteriorating. It also means that it isn't getting better. So I think if you imagine that we just allocated the perfectly fit, healthiest baby in the world as 100%, and a child that was close to death at 10%, then most of these children in the neonatal intensive care unit, by definition, would have to be scoring maybe 30% on a health illness scale. Um, and they could be stable at 15%. That still means they're horribly ill.
mm,
And the idea that you could imply that a child that still had an endotracheal tube down and was being monitored in every way possible was somehow well and stable is nonsense, really.
mm,
If they're well and they're stable, they wouldn't be on the neonatal intensive care unit.
mm.
They shouldn't have been there, or they should have been discharged. So much pressure on cots, on staffing, you would discharge a stable, well child. So yes, you can say that the physiological monitoring was giving consistent results hour on hour, but of course, what you'd want to see is that they weren't stable. That you want to see they're improving.
Mm.
Um, so the word stable, I think, deflects from the fact that these children were seriously ill, and I'm sure all the parents of the children who are admitted to a neonatal intensive care unit are told that their child is seriously unwell and that there could we're hoping for good outcomes, but you have to face the facts that could be really bad outcomes as well.
Yeah, I don't know how much you've seen of the court process and so forth, but I know that you read my book, and based on what you've seen, do you think it's fair to say that the way the infants were presented in court was misleading?
Yes, yeah. As I say, if you're in an intensive care unit, you're very, very, very far away from being well and stable.
Yeah, that's
And again, it's one of the reasons people are in intensive, whether it's babies or adults are in intensive care units, is there can be sudden, unexpected deteriorations.
hmm,
So you anticipate there's going to be sudden, unexpected deteriorations. That's why they're in the unit. So they're still very much at risk, even if at that very moment everything seems to be fine.
hmm, absolutely. So it very much allied to this issue is the obstetric notes
Mm.
from the unit from that were curiously absent from the trial, although that appears to be because the prosecution didn't disclose them. Now, um, can you discuss with us the significance of the fact that they're missing from the trial and the whole investigation, in fact, just the entire picture of what happened at the hospital?
Well, I think again, went on a few neonatal ward rounds, and when the children were being presented to the consultants, the standard thing was this child was born at 32 weeks from a mother who's had five previous pregnancies. There's been rhesus incompatibility. She has systemic lupus erythematosus and diabetes, and this child's problems are da 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 da. And it all has, the child has grown inside the body of a woman. You have to know about the woman's health. You have to know what the background was. You have to know what the complicating possible factors. So just to say it's a 32-week gestation baby who's got pneumonia, yes, that's true, but it's not the whole picture. It's not the whole context. You must have the information about the child. And even if it's something simple like a precipitate delivery, it's the a woman having a fourth baby and the baby was delivered within 2 minutes, well, then you're going to be worried about hemorrhage inside the skull. You're going to be worried about hemorrhage in the liver. Um, so, and if it's even if it's something very common like diabetes, that has a profound effect on the baby and how the baby's going to respond physiologically. So, you can't, in my opinion, consider the baby's clinical condition without knowing about the mother, and that's essential. Now, I could think of reasons why that might be something to do with computerization. For example, it might well be that the maternity records were in a completely separate IT system that only midwives and obstetricians could access. So the pediatricians couldn't access it. And that would be feasible. Or it could just be that there was people weren't interested, which would seem extraordinary,
Hmm.
because you have to know about the maternal health. I know we're going to talk about insulin later on, but the mother can have insulin antibodies, which can cross the placenta, which can interfere with the radioimmunoassay. So, it's a standard to me. Part of the care of a child is to know what the mother's health was and what the conditions were and what the delivery was.
Hmm. Yeah, that's I mean, obviously I've heard that many times, including from obstetricians.
Mm,
It's but I think I mean I made this point when I was at Waterstones when we did the launch event. If I was sitting in the jury, I know now, but when if I'd have been sitting in the jury, I wouldn't have had the slightest idea that the obstetric and maternity picture was it A important and B had been
mm,
omitted from the
no.
court process, which I think is scandalous, really. Especially given that we now know the defence requested
Mm,
these notes. It's not as if they didn't request them;
mm.
they just weren't allowed access to them for some reason, which just seems completely wrong.
Yeah, I can't understand why they're not allowed access. And as you say, it seems completely wrong. As to the jury not being aware of that, I think we're going to discuss about legal process and so on, and
Mm,
whether there should be judges who are specifically expert in medical cases. And it's the job, I think, to defend trial by jury, but it's the job of the judge to make sure that they're presented with information that's complete and understandable.
mm, absolutely. So let's discuss the triplets that were in Lucy's case. This is
Mm.
children O, P, and R. R doesn't actually appear in the indictment. Um, so I know that you felt quite strongly about this. Firstly, I suppose the simple question is, should they have been on the unit in the first place?
Well, I don't know all the context, but I know that I worked in combined medical antenatal clinics during my training and once I qualified as a consultant. And when I was a consultant, I was working in a district general hospital, very similar to the one that in Chester. So when I was working with the obstetricians, if we'd had a woman with triplets and we were planning her delivery, we would not have planned her delivery in a district general hospital. We would have at least referred her to Brighton,
Hmm,
because the chances of deaths, major complications, premature delivery, risks to the mother are much, much higher in triplet pregnancy than in twin pregnancy and way higher than singleton pregnancy. So we would not have, we simply wouldn't have got into that context. Um, of course, you might, for all we know, or for all I know, the mother might have been driving from Scotland to Cornwall and happened to go into labour in Chester.
hmm,
Well, if that was the case, then I would have expected there to be blue light ambulances heading from Liverpool with a full support team to come and help to get these babies into the cots, into the incubators, and back to a place of safety. Um, so whatever the context and the background, how we've reached the stage where triplet pregnancy, there can be a plan for that to be delivered in a district general hospital. That's something I can't answer how that's arisen, but if that's become the norm, then it seems far away from what it should be.
hmm. Why is it so important that triplets are in the appropriate level or quality of neonatal unit?
Well, the delivery is likely to be even more premature, and the babies are going to be much smaller, as well as other potential risks like fetus to fetus transfusion and such like. So they're going to be smaller. There's three of them to deal with simultaneously. So you've got to have three people who can intubate,
Hmm,
three people who can ventilate, three people who can cannulate. And if you've got this, we understand that unit was already hard stretched. So why would you do that when you would hope when you've got a large teaching hospital available with an expert pediatric centre that deliver the children there, and
yeah.
much easier for the transport the babies whilst they're still inside the mother than wait till they've been delivered and then try and transport them.
Hmm, absolutely. I guess we should say, just to, as an adjunct to that, that there isn't strong evidence that they were particularly great at intubation, such like on this unit.
Mm.
They made a lot of that they had a lot of intubation failures, they had a lot of failures with basic processes that you've just described, and that would be troubling, for, I suppose, for any infant. But then with triplets, it becomes maybe an even more serious issue.
Well, when
Uh,
you're talking about the level of staffing, the junior doctors in that area, I mean that would be a major concern for me.
mm,
I'd have loved to do pediatrics, but I knew I wasn't very good at practical procedures, simple
mm,
things like cannulation and intubation, so I couldn't do pediatrics because it's so difficult.
mm,
And to expect a doctor who's on a GP training scheme or maybe just 2 or 3 years into a career in pediatrics to be able to intubate a tiny baby in the middle of the night, it's just not feasible. And
mm,
certainly unless they've got supervision, uh, different, maybe you've got to add pediatric anaesthetist on hand who's watching them do it and says, "Oh, no, you've messed it up the first time, I'm doing it now." Um, that's exactly the sort of thing you're going to run into difficulties with, whether it's cannulation, intubation, chest drains, draining fluid out of the abdomen.
mm,
All those things require a lot of not just knowledge, but the expertise. You've done it,
mm.
and you can do it. And these tiny babies are so difficult, so fragile.
Yeah. it's interesting to hear you make that point because I have thought about myself that I'm sure I could learn the medical theory of things, but I
Mm,
don't think I'd be very good at. I'm not very good at practical. I'm not practical.
yeah.
I can't see myself being any good at intubation.
Mm.
Um, so could you put in? It might be difficult, but could you put into context, the pressure, how tricky it is to do these things?
Well, intubation first off isn't that easy. So even if it's adult intubation, a patient on my ward has a cardiac arrest, somebody's got to come and put a tube down.
Mm,
So under those circumstances, it wouldn't be uncommon for us not to be able to get a tube down until an anaesthetist arrived, and that's in an adult.
mm,
Um, and even if you get the skill, then you have to be using it on a regular basis to maintain it. So um, a medical registrar might be on call one night a month. How is he going to maintain his skills in intubation? And then you're dealing with these tiny children where it's so much more difficult.
mm.
Um, you've got to be able to see into the airway. You've got to be able to get the tube into the airway, make sure it doesn't go down into the esophagus. It's a very, very difficult thing to do.
Yes, absolutely. Um, so another thing that we discussed, which I think is a major, I think it's fair to describe as a major red flag for the whole prosecution, is that there's this extraordinary number of alleged mechanisms of harm. So
Mm,
I was discussing them with someone I interviewed previously, and there's at least eight in this
hmm
court case, including air embolism, air milk through a nasogastric tube, insulin, extubation, smothering, physical trauma. What do you make of such a wide range of proposed mechanisms?
It's completely bizarre and incomprehensible why they should have suggested somebody would resort to this vast array of apparently attempts at murder. Um, Letby has been found guilty of murder. Now, murder is something that's thought of in advance, usually. We see people get away with manslaughter because of impulsive behavior, which we think perhaps should have been done for murder.
Hmm.
But the prosecution case is that she planned all this stuff. Um, so it's a really odd selection of ways to try to kill a baby. And my understanding, again, I'm not an expert, is that serial killers generally stick to the same modus operandi, or very minor variations on it. So we know Shipman killed all his people with opiate overdoses. Um, so he stuck to the same thing. Beverly Allitt killed people with insulin. It's not a particularly easy thing to do, kill somebody with insulin, but she killed them with insulin. So this is really odd that you've got 7 or 8 different proposed mechanisms. Now, if it was planned or had been in the back of her mind for a time, it seems to me that the police would have found evidence on her computer of searches. How do you kill a baby? By smothering them. How do you kill them? By taking the breathing tube out. How do you kill them with insulin? How do you kill them with that? How much insulin do you need? What sort of insulin do you need? No evidence like that has been proposed. That that she was obsessed with ways to kill babies. So then you're left with this idea that somehow in the middle of a shift she just thought she was going to try some way of killing a baby that she hadn't researched or thought out. So there's a great lack of evidence, collaborative evidence, that she'd planned these murders and gone about murdering the children in a thoughtful way, in a sense.
Yeah, I think I should say as well that some of the allegations I think we can say now are preposterous.
Mm,
The Child O case has completely collapsed because it requires this subcapsular hematoma to be accounted for, and that somehow Lucy Letby caused the rupturing of the
mm.
hematoma. So, she's accused of punching the infant. I mean, there's just literally no evidence for that.
Uh,
It's ludicrous.
yeah,
Do
anyway,
you agree with that?
yes. I mean, subcapsular hematoma of the liver and bleeding into the cranial vault, well recognized complications of precipitate delivery prematurity.
Mm.
So, and that, I think they suggest that she'd punched the child or something to
Yeah.
cause this. Well, it's just incredible. And we've come up with that hypothesis, I think, when you've got conditions that cause those problems very apparent. And also, if the child had been through a post-mortem, the pathologists were completely content that there was a natural cause for death.
Mm, absolutely. So speaking of plausibility, we're going to talk about introducing air into a baby's stomach through a nasogastric tube and this
Mm.
causing the deterioration or death of an infant. So how do you feel about the plausibility of that?
Uh, One word, it's implausible. Um, as I said earlier on, one of the reasons nasogastric tubes are put down is to relieve a full stomach. So anything's put down, if that's the reason you put the nasogastric tube down, the stuff will come out. Um, and if there's another reason for putting it down, then it's very likely the child's going to burp the fluid up or vomit the fluid up. Certainly before it gets to the set. I mean, you can put vast quantities of fluid or air into an adult's abdomen without it affecting their breathing in any serious way at all. So the idea that you could put enough into a stomach to cause complete failure of the respiratory system, again, is just implausible.
Hmm. I mean, do you think it's even practically possible?
Well, I mean, obviously you're going to have to, it depends. There are two different types of nasogastric tube. There's one called a fine bore tube, which is for feeding.
Hmm.
And they're so fine bore that it'd be difficult to get large quantities down. If it was a large bore one, then perhaps you could get, say, 100 mils of milk down it or something. But then as soon as you disconnect whatever you're injected with, it comes straight back up the tube because it's a large bore tube. So, no, nonsense.
Yeah, this is just a nonsense mechanism.
Yes.
Yeah.
Yeah.
Um, and another aspect of this that I think is also nonsense for me, I think it's one of the biggest red flags. So it's one of the things that I first heard about and I thought that's unusual, is you have this incredible number of attacks. But bear in mind, Dr. Evans thinks she murdered other infants or tried
Hmm.
to in quite large numbers. He thinks there's dozens more attempted attacks. Um, you've got this wide range, enormous number of attacks, supposedly, and this very wide range of murder methods that we've
Mm.
discussed. It's a working neonatal unit, and not only did not another nurse or doctor witness an act of deliberate harm, but also we've seen all these statements now from the Thurl inquiry from nurses who obviously work closely with Lucy, and they say we didn't suspect a thing.
Mm.
So given the practical realities of an intensive care environment, how likely do you think this is?
Very unlikely again.
Hmm.
Um, One of the reasons this came to people's attention was this alleged spike in the mortality. Well, if Letby had been killing even more babies, there, there would have been a huge spike. And it wouldn't have just meant that Chester was in the bottom, I don't know, three or four performing hospitals in the country. It would have been way out
Hmm.
if she'd been killing all those ones. It would have been a serious outlier, not just within the normal bounds. And again, I haven't looked at all the details or the statistics, but my interpretation of that spike is that spikes are normal. What would be abnormal if you had a straight line that showed the same thing all the time. Um, and a spike might need interpretation and might need investigation, but actually, the way that we've set up the whole statistical analysis of performance in the NHS means that normal things get marked up as abnormal.
Hmm. Hmm. Yeah. What was I going to say?
Well, I was going to say on that, it's interesting. I don't know if you know about this, but in blood
Yeah.
tests and in statistics on mortality and so on, in healthcare, we all concentrate on mean plus or minus two standard deviations. That means if you make 100 measurements, five of them will be listed as not normal.
Right.
Now, outside medicine, in engineering, production lines, whatever, Deeming, who was the godfather of quality after the Second World War, he was only interested in things that were plus or minus three standard deviations, which meant one in 400 would be seen as abnormal. So all this spikes and bumping around the bottom of the normal distribution curve that people say, oh, this is a poor hospital because it's at 85%, is actually a nonsense. we should only be interested in the way outliers. And if that be going back to your point, if she'd been murdering lots of other children, it would have become one of those 1 in 400 cases, not just an ordinary wobbling.
Mm, absolutely. Well, yeah, what I was going to say was, I haven't shown you the tour of, I mentioned there's a tour of a neonatal unit
Hmm.
on my channel, and it's very, very compact. Um, the nurseries are nursery two and nursery three are right next to each other, and then there's a corridor. The corridor's right on top of the nursery. There's an area where the nurses would have congregated to do research and
Hmm.
work and such like. Nursery one is separate through some double doors, but again, the corridor just goes straight into the nursery. There's obviously, as you will know, there's windows, massive
Hmm.
windows outside. Can you put into perspective for us how busy these units are and how many people are coming and going and parents and such like?
Well, again, I haven't worked on neonatal intensive care units,
Mm,
but I have been to adult intensive care units. Yeah, and there's constant to and fro. People are visible all the time. They're usually designed so that
mm,
everybody can be visible and easy to access the intensive care beds or cots in the neonatal intensive care unit, so you can get help rapidly and quickly to assist you. So I think that, it should have to be an extremely cunning person to undertake all these bizarre methods of killing a child without being observed.
mm, absolutely. So we're going to discuss Lucy being accompanied by a student. So if people don't know this, it's not, I think, common knowledge that Lucy did have to look after students during her time on the neonatal unit, handhold them and
Hmm.
show them the ropes, I think you might describe it as. So you deem this to be significant. So can you expand on that, please?
Well, I think firstly, it's significant that she was given that responsibility because that implies that she was not only a trusted and experienced member of staff, but also able to supervise a student and to welcome a student onto the unit and give them an induction to the unit. Um, to be honest, there's probably very little that a student nurse would be able to do in a neonatal intensive care unit. It'd be more, this is what goes on, these are the things that happen, this is how a really well mum and baby can suddenly have these things occur. But again, I think going back to your bit about how much under observation should be, if she had a student with her for a shift, very likely she'd spend the vast majority of that time with the student throughout the shift, and the student would be watching her. And also the other bit about it is that at the end of attachment, students are usually asked to give feedback about their supervisors. So, if there had been cause for concern, there might have been something raised through the students' nurses. But again, we're not aware of anything about like that.
Hmm. Yeah. And do you think, you know, do you think that makes it harder logistically to supposedly have conducted these crimes?
Yes, well, you probably well, you certainly have to conduct them on days when you didn't have students,
Yeah.
which I'm sure you would know in advance whether you're going to have a student or not. But you'd have to plan that you're going to do the things when you didn't have a student.
And the same thing applies, although these cases have been thrown out. Um, Lucy supposedly, I think some of the new cases that went to the Crown Prosecution Service involved, well, I know they involved her being at Liverpool Hospital,
Hmm.
Liverpool. But in that case, she was the student. She was the person on the placement learning
Yes.
from people. So to me, that just seemed utterly ridiculous because there's no explicit allegation. There's no indication that any infant collapsed. There's no observation of anything, and
Mm.
surely Lucy would be accompanied all the time. So,
Yeah.
so, so do you have any thoughts about that?
Well, yeah. Certainly, the student should be accompanied all the time.
Yeah.
And as I said already, the role for a student nurse in those placements would be very limited. Um, in the same way, if a medical student went to an intensive care unit, he might be given the job of making cups of tea, so you have a conference with a relative or something. But the rest of it is just explanation. Although she was on a specific neonatal intensive care course, that would be different. But she would be supervised for everything that she did and wouldn't be left to carry on and undertake procedures unsupervised.
Mm.
Um, so, again, the Crown Prosecution Service have said they're not taking action. They obviously haven't got evidence against her for those cases.
Mm. Absolutely. So let's talk about the insulin case. I know this is an area of will be an area of interest for you, given your background. What initial observations do you have about the insulin cases, speaking of someone with endocrinology experience?
Um, Again, it seems very bizarre. Um, I think I've already mentioned that certainly in an adult or in a child, it's very difficult to kill somebody with insulin. And it's certainly not a quick, easy way to kill somebody. So proposing that this is a deliberate attempt to murder somebody is odd. If you give somebody too much insulin, they can certainly end up with brain damage, and then the consequence of brain damage could lead to death down the line. Or um, a diabetic who dies at home with too much insulin in the body, they've usually collapsed, gone into a coma, vomited, and choked on their own vomit. Um, so, firstly, it's not a particularly effective way to go about killing, is the first thing. Again, I'm not an expert in neonatal insulin levels and assays in neonatology, and it's clearly, again, a very complex area, and one which I suspect Dr. Evans knows even less than I do. And I think it's particularly important if you're claiming to be an expert that you know the limits of your knowledge and seek out information elsewhere. Um, Next, I was wondering, why did they measure the insulin levels? There's only really one reason to measure insulin levels is that you've got pathologically low blood glucose, which you don't understand. Um, and that would either be because the body's making it itself, something called an insulinoma, or because somebody had injected insulin into the subject. Um, then measuring insulin levels during my career, if I was intending to measure insulin levels, I had to go to the lab and tell them I was doing it beforehand because it's not straightforward. You have to take a simultaneous glucose level, insulin level, C-peptide level, and possibly some other tests as well, which all have to go to the lab straight away. The insulin one has to be spun down and frozen at once, and it's an expensive, difficult assay to do. So you have to have a good reason for having done it. If you've got a good reason for having done it, then why wasn't the result noted until many months later? Um, and then if these, I think in one case, the glucose level was high when they measured the insulin level. Well, no surprise, big surprise. If I put your glucose level up, if I give you um, an ice cream to eat, stuffed full of sugar, your insulin level will abruptly go up and your glucose level will go up a little bit. So there's no value in a glucose level measuring insulin when it's high. Um, so there has to be a pathologically low glucose level and a simultaneous C-peptide and insulin level. And certainly in your book, I got no indication that those three things had all been measured. In my career, the usual problem was that people would remember to take the insulin level and the C-peptide level, but they'd rely on some finger prick test for the glucose, which is nowhere near adequate for making a diagnosis. Um, and then once the samples were sent away to the lab, as I think went to Guilford from Worthing, they would do extra tests to test for insulin antibodies and all this sort of stuff. And you needed, if I was going to diagnose an insulinoma, I needed to have at least three sets of results that were all consistent. Um, and I didn't have much experience with, well, or any experience that people being given insulin as a deliberate attempt to harm them.
Mm.
But in those circumstances, it's very difficult to get the samples because the person's clearly extremely unwell because of the low glucose level. And the thing you want to do, everybody wants to do, is fill them up with glucose and get them conscious again,
Mm.
by which time the samples are meaningless. Um, so it's, again, an area fraught with difficulty, and interpretation of the results is not straightforward.
Mm.
Um, and again, you need follow-on tests. If the person has a very low glucose level, is their thyroid gland functioning normally? Have they got enough steroid hormone in the body? It's not just straightforward, oh, it's somebody's given them insulin.
Mm. Yeah.
Uh,
Sorry, go on.
And I think the other bit which you alluded to, a question you might be coming to is, well, which insulin is it? So the stuff that you've got going around in your body at the moment, human insulin, is what we used to use pig insulin and beef insulin, which is different from human insulin. Then they've got all these new analog insulins, Humalog, Novorapid, whatever. So in the forensic case, I'd expect them to have done some work, find out, well, was it Novorapid that was used? Or if it was Novorapid, do they stock Novorapid on the neonatal intensive care unit? Has the stock gone down? Who's got access to it? Where's it kept? Or if it was some other insulin, Actrapid, is that on the unit? So, again, to come to a conviction beyond reasonable doubt, I would expect people even to have raised these as possibilities
Mm.
and maybe say, well, we can't do it. There's no evidence. It's much too late to do that. But at least that would have raised the possibility that you would be able to identify whether it was Humalog, Actrapid, Humulin S, or pig insulin that had been injected.
Yeah, I mean, when I first heard about this, I obviously felt I need to understand the insulin case as well as I can because it's the only thing where there's anything even
Mm,
remotely solid.
yeah.
And I found it extraordinary from the very start that there was no court discussion, let alone allegations of she accessed the insulin here,
Mm,
she accessed this much,
yeah.
here's the audit for that,
Yeah.
etc., etc. It's just
Mm.
completely absent
But
from the entire
mm,
court case, which I find
it's,
incredible.
yeah, in my experience, on most wards, insulin is kept in a locked drugs fridge.
Mm,
Um, and I would have thought that would certainly be the case on a neonatal unit. On adult wards, people have their own insulin supplies and sometimes allowed to keep them, but that doesn't apply here. So again, had she got a history of accessing the drug fridge inappropriately,
the answer is no.
times
The
when
answer is no, totally.
you know, when there's no child with diabetes
Mm,
on the unit, no, yeah, or was her niece a diabetic and she was asking for some of her insulin? Something,
mm,
nothing like that.
no.
Um, Quite apart from that, they seem to have proposed that she injected the stuff into a bag of fluid
Yeah.
for some random attempt at murder. Well, how do you get the insulin into the bag of fluid without evidence of tampering? Um,
Yeah, we believe that to be impossible.
mm,
We've done some research on the bags they had and the cap. We just think it's impossible.
mm, yeah,
And another thing to mention, actually, as well, we talked about logistics earlier on. Why suddenly start injecting infants with insulin? Like you supposedly killed infants with air, which is much harder to detect. Why suddenly halfway through this killing spree have you decided, oh well, I'll have a crack with insulin now?
well, I mean,
Um,
actually, I mean, if she had injected air into the central veins, that would be easy to detect.
hmm,
And in fact, she hadn't done it, and that's why they didn't detect it.
yeah,
Um,
fair enough.
but insulin is let's say if you give a big dose of insulin into a vein, you'll
Hmm,
make the blood glucose level go low, and you can cause brain damage because the brain can only use glucose for food,
hmm,
whereas the heart will carry on beating because it can use alternative fluid sources. So it's
hmm.
not an effective way to kill. You can harm people badly by it, but it's not a good way, sensible way to go about trying to kill somebody. Um, and then actually, I mean, it would be quite difficult to detect because of all these trouble questions we've raised about the assays and the follow-on tests and the
Yes.
complicating factors. Yeah.
So let me ask you some follow-up questions regarding what you've said already. The first one is you mentioned low glucose.
Hmm.
Certainly, in one of these cases, there is an extraordinarily high reading for glucose.
Yeah.
In fact, the indication is that the machine can't even properly
Mm.
measure. It
Yeah.
goes beyond the extent of what the machine can measure. So
Right.
what does that tell you?
Well, they shouldn't have been measuring the insulin level in the first place. It's completely. If I manage to push your glucose level up from your sort of ordinary range of 4 to 7, something like that, if I could put it up to 20, your blood would be full of insulin because it's trying to bring the glucose level down. It's one of the most powerful physiological systems is to keep the glucose level normal in the body, that and the pH. So if you've got a high glucose level, of course the insulin level's high. no surprise whatsoever. Um, and so, it's in its extent, it's why did the lab even measure the glucose?
Mm,
Because the labs I worked with, I mean the insulin, sorry, the labs I worked with wouldn't measure the insulin unless the glucose had been proven to be low.
mm,
You just couldn't get it through the algorithm. You're doing this test because you think there's too much insulin in the system. If there's too much insulin in the system, the blood glucose will be low. It's not low, you're not getting the test.
yeah, that's very, very interesting. Um, you also were talking about insulinoma and
Hmm.
how when you're interpreting the biochemical results related to insulinoma, this requires considerable care. You did speak about this a little bit already, but
Mm.
can you kind of go into more detail on that, please?
Well, yeah, I mean, first of all, an insulinoma in a neonate must be vanishingly rare. Um, it's you can get it certainly in older pediatric cases, but they're predominantly it's an adult condition predominantly. Um, and an insulinoma is when the pancreas, which makes the insulin, and parts called the islets of Langerhans, makes insulin, and you get a benign or occasionally a malignant tumor that produces insulin when it shouldn't be. So then you get insulin released into the circulation, which pushes the blood glucose level down. Um, and this is a very serious condition, but it is difficult to diagnose because you have to get a blood sample when the glucose is low, say below 2.2 millimoles per liter. Then you have to have an insulin level and something called a C-peptide level, um, which is a complicated issue that every time you release a molecule of insulin, you get a molecule of C-peptide. But when you're using insulin from outside, somebody's injecting insulin, there isn't any C-peptide in it. So if you find low glucose, high insulin, high C-peptide, the likelihood is pointing to an insulinoma. But I say to get just in the midst of all the bureaucracy in the NHS to get all that done, the sample handled properly, then get it analyzed, it's a major undertaking. Um, so if let's postulate that these consultants thought there might be an insulinoma in the child, which is extremely unlikely, then they would have been pursuing that vigorously with repeated tests and saying insulinoma question mark. Um, so, but say crucial to that is you have to have a low glucose level. You can't interpret the insulin levels once the glucose when the glucose is normal. It's just working ordinarily.
Yes. Yeah, interesting. And the other follow-up question I really want to ask you is regarding Guilford. So you mentioned Guilford. This is the place where they conduct follow-up testing on these results.
Mm.
There were some very odd things that occurred in the court case with regard to what the jury was told. Um, do you think it's a major defect of the court case that there wasn't follow-up testing done?
Well, again, I don't know what they put on the request form for why they were asking for the insulin levels.
Hmm.
Um, and as I said, you'd expect it.
Let me just tell you something that you may not
Mm,
know. So there is a laboratory note that's in the Thirlwell documents where the person in the laboratory, we don't know what was put in the initial note
right.
sent to the laboratory, but there is a note from the laboratory where they say blah 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 suggest sending to Guildford for further tests.
Hmm.
So we know that was suggested,
Yes.
but it just didn't happen.
No, well, you can't tell too much from that, apart
Hmm.
from, the cases, the handful of cases I had with insulinoma over my career, maybe five,
Hmm.
were so interested in the cases that you wouldn't let something slip through. And would have been talking to the pathology department, and they would have been saying, "Yeah, this, although we're Liverpool, we're Alder Hey, we're fantastic. You've got to send it to Victor in Guildford for his team really to work through it all and find out what's going on. And they may come back and want extra samples and things." So, I mean, that just suggests that going back to these cases, the consultants in charge weren't that convinced that they're going to get a positive diagnosis that they needed to be pursuing the thing actively.
Hmm. Absolutely interesting. So I guess the kind of overarching issue here is how comfortable would you be using a routine hospital insulin assay as the principal evidence of deliberate insulin poisoning in a criminal case?
Um, I wouldn't. No. As I say, first of all, once the person arrives in A&E, they're clearly unwell with a low glucose. It's really unusual for them to take the samples in that situation because they just fill the person up with glucose, assuming they're a type 1 diabetic who's used too much insulin. Um, so there's difficulties with getting the samples. But then forensics is something very different from ordinary routine clinical care. Um, and it's actually, I mean, it is rare for us to think that somebody's going to be deliberately harming our patient. Perhaps we should be more aware of it. I've certainly had patients who've been deliberately harmed by relatives and such like. Um, but once you're getting into forensics and beyond reasonable doubt and making sure that the innocent don't get convicted, you'd need a whole lot more evidence just than a blood insulin level.
Yes. Yeah, that's fair. Um, and we have spoken about this already, but I do want to reiterate this. So the prosecution case involves the suggestion that insulin had been added to this infusion bag, which was subsequently administered to a baby. We should emphasize that there is no proof of this because they threw the
Mm.
bags away. So it's an absolute, the most generous way you can describe it is it's a hypothesis. That's
Mm.
a generous description, I think. There's no evidence to support this. How do you feel about the feasibility of this?
It's just not feasible. In general, again, my experience of bags of fluid during the 21st century is usually the bag of fluids inside another bag. So you'd have to take out the outer coating to try to then inject the insulin into the bag. Um, if you're doing it, you'd have to, imagine, inject a lot of insulin to do it. And then this is going to be a random death. So you've planned a random death, which again, of course, people would say that's just because she's so clever and manipulative and smart. But just an improbable idea that this would be a way that you kill a child and impractical. Do we know what the bag was that they said it was in? Because if it's got any glucose in it, then it's not, it's going to be, the insulin's going to be counteracted in any case.
Yeah, well, this is one of the things that I was told, of course, that it doesn't make any sense again because you've literally got the antidote to the poison in the bag. So yeah,
Mm,
this is one of the points that was made to me by an expert. Of course, the fact that they haven't retained the bags and this is all,
mm.
I
Yes,
mean,
it's a substantial lack of evidence. I mean, it would be very unusual to retain a bag. The times when we retain bags immediately, as if a person's having a blood transfusion and has a reaction to the blood transfusion. Then you stop the blood transfusion straight away. You keep the bag, and it gets sent away to find out what the hell's gone wrong. Um, but most bags are just thrown away at the end.
yeah,
So you you haven't got any evidence
no,
that
no.
you know. And again, if we go back to that, if that was the child where the glucose level was high, no surprise there's a high insulin level. And if the insulin level was, the glucose level was anywhere above 2.2, um, you can't interpret the insulin level.
What do you think about this sticky insulin thing that was mentioned in court? Now,
Well, I mean, we're always taught, and I think it's true that we sometimes put insulin deliberately into a bag of fluid to help to maintain homeostasis.
hmm,
And that would particularly be in somebody who has what's called type 1 diabetes, where their body doesn't produce any insulin. And we're all taught that a little bit of it sticks to the plastic. So you might have put in 6 units in a liter, and maybe what you're getting delivered is 5.8 units. But so I don't see that that's of any particular significance or relevance, other than the fact that yes, sometimes doctors deliberately ask for insulin to be put into an infusion fluid, particularly if it's 5% glucose.
yeah, that's interesting. I mean, certainly when I've spoken to experts regarding the sticky insulin theory, they've been pretty scathing. So
Mm,
yeah. So I guess the last thing that I'd let me just shut the door. Just hold on. Because the radio just come
yeah.
on. Just bear with me a second. Um, Sorry about that, viewers. It's just the radio's just come on in the other room, and you'll hear it in the back. You'll hear it in the background. Um, yeah, so I guess the last thing I'd like to ask you about the insulin cases, and I think it's the last thing I'll ask you today because I've got many other questions, so we can go through them on another occasion. This is presented as a smoking gun. Is it a smoking gun?
No, no, I can't see any way it's a smoking gun. It, it's just there's no evidence around it that
Mhm.
this could have killed the child, or even it was an attempt to kill a child. It's the whole thing is full of implausibility to me.
Yeah. That's great. Thank you for speaking today. We're going to pause there because, as I said, I've got many questions left. Dr. Caldwell sent me an academic paper that I could go through.
Hmm.
I haven't had time to do that yet. I'd like to show you the ward round papers that he's done, so we can maybe discuss them in more detail. So I'll get him back soon to have a second discussion. But yeah, we really appreciate your time today and sharing your expertise. Thanks for getting in touch, in fact, because it's really valuable and really appreciate your time.
Thank you. I hope it's of some use.
Oh, absolutely, absolutely. And we'll definitely have you back again soon.
Right. Thanks, Sue. Thanks, Chris.
Thank you.
Okay.